Right, let's make a start. Thank you everyone for joining the meeting on cellulitis. This is our first of hopefully a few that we're going to put on around infections from the CCG Medicines Management team. And do please give any feedback at the end of the session, or ideas of what else you would like going forward would be great. We're going to record the session, so firstly, if you don't want to be seen on the recording, do take yourself off camera. We'll put the recording on the BNSSG training hub, and hopefully that will be out in the next week, so you're able to share with colleagues across the system who might find this session useful. We were going to ask you to put questions in the chat, but typically I can't see the chat for some reason today. So actually, could you put your hands up for questions at the end, and we can facilitate Martin being able to answer those questions. And finally, I'm really grateful to Martin Williams, who is consultant in infection and medical microbiology at UHBW, as well as being their Director of Infection Prevention and Control, and no doubt many other titles, to talk to us on cellulitis. Thank you, Martin.
Thanks, Liz. Shall I share my screen?
Please do.
Okay, so I now have lost all the sight of everybody else, so that's okay. But thank you for asking me to give this talk, something I promised to do a little while ago, so I'm glad to have the opportunity. We all know and have seen patients with cellulitis, but it's actually surprisingly difficult to diagnose, and actually there are lots of uncertainties about management. So what I'd hope to be able to do is talk a little bit about cellulitis. So my objectives are to discuss and introduce a new
Sorry, can we just ask everyone to put themselves on mute so that we can hear Martin? Thank you.
So I plan on introducing a new term to people, which is non-purulent cellulitis, and I'll explain what that means as I go forward. I can't give a talk without showing a plate. I'm talking about microbiology. I've got hopefully some illustrative cases. I'd hope to make them interactive, but I think it's not going to be possible. But what I may ask you to do is to look at the options and think yourself what you would have done in that situation. And then introduce what we have now produced, which is the cellulitis pathway for the BNSSG. And then I'm very happy to take questions, so hopefully this shouldn't take too much of your time. So there's a term called non-purulent cellulitis, which increasingly we see in the literature, and really it's to differentiate the conditions of erysipelas, cellulitis, and to a degree necrotizing fasciitis, because it really isn't a purulent process. But it's to differentiate between cellulitis and non-purulent disease, erysipelas as well, and really to differentiate it from these problems. So this is a diabetic who's got a rub, who's now developed a wound infection. This is another individual who's had tension sutures and again has a wound infection. So really it's to differentiate between things like carbuncles and abscesses and wound infections, primarily because the microbiology is different. And that's the main reason for differentiating between the two. The management also is a little different, but primarily it's the microbiology is different. And the reason it's different is that we know that for non-purulent cellulitis, that the usual causative organisms are the beta hemolytic streptococci, primarily Streptococcus pyogenes, group A strep, or increasingly we are now seeing things like group C or G streptococci causing infections, particularly in older individuals. Purulent cellulitis is different. Again, we still see the beta hemolytic streptococci as a significant component of that infection, but we are starting to see now this is where Staph aureus becomes an issue, and particularly in certain populations we see MRSA as an issue as well. In certain situations, gram negatives may be important. There's a lot of want to identify Pseudomonas aeruginosa in chronic wounds. In the main, actually, it's not really a causative organism. And then we've got some of the minutiae, things that can cause infections. These are gram negatives, but really we only ever see in certain situations. So Erymonas hydrophilis, exposure to brackish water, Vibrio, we tend to see it really as a tropical infection, but associated with salt water. And then Pastorella, we see not infrequently, but this is associated with animal bites. So the reason of differentiating the nature of the illness is partly because the treatment of these particular conditions is very different to the treatment of non-purulent cellulitis. So I have a case. This is something which I guess most people are very familiar with. This is a man who's got a red leg. He's otherwise fit and well. He has no allergies. And he essentially starts with a history of feeling hot and shivery, then notice the rash in his leg, and you can see in the photo, I'm not sure how well that presents, but you can see his lower leg is erythematous, and he's got a degree of lymphangitis, which is tracking up into his groin. He is hot, he's a bit tachycardic probably for him and his age, but his blood pressure is normal. So really, from a diagnostic point of view, I don't think at this point it's particularly difficult. And then we move into what's the best treatment. So the other thing to bear in mind, of course, whenever you see somebody with cellulitis, there's usually a portal of entry in. And if you lift this chap's foot, you can see he's got a wound between his toes, and that's probably the portal of entry. So what are the best treatments? So there are a variety of treatment options. So if you think what you would do if you were faced with this individual, would you be giving combinations of penicillins? Would you use flucloxacillin? A lot of people give comoxiclav, it's a broader spectrum penicillin. There's a fondness for clarithromycin. Are you sufficiently concerned about the patient to admit him for intravenous therapy? Or is there something else you might do? And I might give you a second to ponder that. So how do we manage patients with cellulitis? Well, there are lots of guidelines. These are international guidelines, just a handful. There are 2 British guidelines, which are the CREST guidelines, and NICE have actually produced guidance in the last couple of years. But there are Spanish, Korean, French, German guidelines for the management of cellulitis and soft tissue infections. There are also other societies like the Lymphedema Society have also produced guidance. The interesting thing from this, of course, actually, is that there's lots of guidance. That's probably because people don't really know how to manage it. And most of these guidelines are based primarily on expert opinion rather than on an evidence base, because there's not that much of an evidence base, and I'll highlight that shortly. This is a piece of work that we undertook a little while ago, actually. Not only are there national and international guidelines, but each hospital trust and presumably each commissioning group have their own guidelines. And we just set about looking at the different guidelines which were available. We looked at 23 sets of guidelines on the management of cellulitis, and each guideline had an algorithm. It's primarily based on flucloxacillin, as you can see, but there's quite a big difference. There's quite a big difference in the dosing of flucloxacillin depending on whether individuals have severe or non-severe infection. And that in itself is quite an interesting discussion, how you define severity. But it ranged from 500 milligrams 4 times a day up to 2 grams 4 times a day, and that's an oral dose rather than an IV dose. So there's some inconsistencies with just the dosing of flucloxacillin. And then also we went on to describe that there was quite a number of inconsistencies with the choices of antibiotics for oral therapies for individuals who claimed a penicillin allergy. And again, lots of macrolide, clindamycin appearing, but other drugs as well. So there's a lot of uncertainty, and again, a lot of individual areas and regions and hospitals have their own particular treatment algorithms. Of note, the key thing actually is that for oral therapy, clarithromycin is the preferred. And again, I'll go on to talk a little bit about why that may not be the best choice. The other thing of note, it was quite important actually that the duration of treatment, again, I'll talk a little bit about duration in a couple of slides, but the duration did vary significantly from guideline to guideline. Again, there's not a lot of consistency about duration. So why do we tend to favor penicillins? Why do we use flucloxacillin? Why do we favor certain drugs and not other drugs? So these are just this data is from UCAS, which is the main body in Europe now, which defines antibiotic susceptibility of organisms. And what I've really done is just looked at an organism. So this is Streptococcus pyogenes, and looked at the various antibiotics that we could use. So I'm hoping you can see my arrow, but essentially each of these panels are very similar. This is an increasing antibiotic concentration, that's the antibiotic, and then this is just the percentage of organisms that have that particular MIC. Anything which is down this end is very sensitive, anything up this end isn't. And you can see for penicillin, Streptococcus pyogenes is very sensitive, the MICology is actually very favorable, very low concentrations of antibiotics required to inhibit the growth of this organism. If you look at oxacillin, oxacillin is very similar to flucloxacillin. Again, you can see that there's actually the MICology, it is very favorable in the fact that it's down towards this end of the graph. And in the main, oxacillin, flucloxacillin is seen as very active against Streptococcus pyogenes. And then when you look at oxacillin, and the reason I've included this panel is because these are the MICs for not group A strep this time, but for Staph aureus. And you can see actually flucloxacillin is active against Staph aureus. Blue means that it's active, but actually the MICs are a little bit higher, and so flucloxacillin is not as active against Staph aureus, though it is active, compared to penicillin. But also now we're starting to see issues of, these are the MRSA, so flucloxacillin will not be active. So we tend to use flucloxacillin because it's very active against group A strep. And occasionally we find that individuals who've got cellulitis have Staph aureus disease and it's not streptococcal, and therefore flucloxacillin will give us some additional, slightly broader cover. Thinking back about the guidelines, actually lots of individuals, as I've said before, macrolides are commonly used if somebody is allergic. If you look at the UCAS data, more than 10% of strains of group A streptococcus are macrolide non-susceptible. And that's a problem if you're facing somebody with an infection. We know that if you use a macrolide, 1 in 10 individuals won't get better because of the antibiotic. The other thing to say about people who get macrolides for treatment is actually that they probably already have a history of penicillin allergy, which would be the main reason for using a macrolide. And therefore, when they've had treatments before for their infections, they'll have probably had a macrolide. And therefore, I would argue that more likely to have a macrolide-resistant organism. So macrolides, for me, are probably not the best choice if somebody does claim a penicillin allergy. The guidelines for the BNSSG, we've opted to use clindamycin. You can see here, actually, the rates of resistance to clindamycin is much less than for macrolides, and therefore you're more likely to succeed. And again, I'll talk a little bit about clindamycin a little bit later on, about if you are using clindamycin for individuals. I'll talk about that and about a risk assessment that may need to be considered. If you look at other drugs, we quite like tetracyclines, they're fairly easy, but you can actually see here there's quite a lot of tetracycline resistant in group A strep. So again, likely to fail. And again, cotrimoxazole, there's quite a lot of cotrimoxazole resistance as well in group A streptococcus. So again, as alternatives, if we are using these as alternatives to flucloxacillin or clindamycin, there is a reasonable chance that individuals may fail because the organism is resistant. So we've got a choice of which antibiotic we're going to use. So I'm hoping that most of you would have said flucloxacillin on its own. That would have been a fairly reasonable choice of therapy. And then it's about duration. Again, we get lots of questions about duration of therapy, whether we should be giving short courses or whether we should be giving longer courses because of the extent. This is quite a nasty one. They've got lymphangitis, groin involvement. So whether you might consider giving longer, potentially up to a month. I've certainly seen people who've been doing a month of treatment before. So again, maybe worth just taking a second to think of how long you would normally treat somebody with a lower limb cellulitis. The honest answer is there's not a lot of data on durations of therapy. As far as I'm aware, there have only been 3 recent trials specifically looking at durations of treatment of the same agents. A lot of the licensing studies actually potentially are comparing dissimilar antibiotics, but there are only 3 trials that I'm aware of. This trial, this is an older trial, 2004, compared levofloxacin, which is a quinolone, where they compared 5 days to 10 days, although they randomized actually at day 5, which is a slightly odd way of designing the trial. The interesting thing about that is actually it's about 7% of individuals hadn't actually got better by day 5. So it did kind of suggest actually the 5 days of treatment are equivalent, and there was no difference in outcome between 5 and 10 days of treatment in that trial. This is a more recent study where they have more severe cases of cellulitis, where they were randomized to either 6 or 12 days of intravenous treatment. They were looking for non-inferiority margins and actually were unable to demonstrate non-inferiority, but this is a very difficult trial that they've tried to undertake, and there are lots of issues in that the cure rate was only 50%, and they had a very high relapse rate, but this is a population who had a very high relapse rate as well. So again, there's a suggestion that there probably isn't much difference between shorter and longer courses of therapy, but the study was certainly underpowered from that point of view. And this is a more recent publication from myself and one of my colleagues, where we've looked at data from a multi-center randomized placebo-controlled trial, looking at the route and the duration of therapy, and we compared outcomes for those who had 5 days of treatment to those who had more than 5 days of treatment at 10 days and at 30 days, and there was no difference between those 2 groups. So again, the ultimate role, we believe, is that actually a short course of therapy for most individuals probably is appropriate. There has been a systematic review on the treatment of cellulitis. This is a study published in JAMA Dermatology, which looked at 43 individual studies looking at a variety of different agents, including nearly 6,000 patients. And the conclusion ultimately was there was no one agent better than any other. And the difficulty with the cellulitis trials, of course, actually is that they're powered for equivalence. If you have a new drug, you want to treat soft tissue infections, you power it for equivalence. It makes it much easier to power. And therefore, there is really nothing better than anything else. I think one of the things that did fall out, though, is actually, certainly in the UK, maybe not so much in North America, but agents with anti-MRSA activity for cellulitis really didn't actually have any advantages. So that takes out a certain number of classes of antibiotics. There's not a lot of evidence to support IV over oral therapy. And again, with the most recent paper that we published, again, there was no real benefit of IV therapy over oral treatments for people who could take oral therapies. And again, there were very few evident data to support anything other than 5 days of treatment was appropriate for the majority. So let's go back to the case. This individual comes back 5 days later, feeling a bit better. It's afebrile, his heart rate's recovered, but it's still red. It's a bit swollen, and it's not as painful, and it's not as warm. And the patient's a bit concerned and a bit worried that his treatment hasn't worked and wants advice. So at this point, again, I would ask you to think about what you would do if you were facing this scenario. Would you retreat with flucloxacillin? Would you assume that this is something which means it's fluclox resistant, so giving something broader with gram-negative cover? Would you use a macrolide? Would you use a lincosamide? Would you be worried and admit them to secondary care for IV, or would you do something else? So I'll pause just for a second just to let you think about what the options are. Now, what I really wanted to discuss with you, there are a couple of quite interesting observations. This is data that has yet to be published. I'm in the process of trying to write this paper, but from the trial that we undertook, we have lots of different measurements of patients, physical measurements, and also have lots of blood parameters too. But what I wanted to share with you was actually what we have been colloquially calling what the natural history of cellulitis actually is. So based on a variety of physical measurements that we've made from all these individuals with low limb cellulitis. And what this first panel is showing you is, again, all the slides of the panels are very similar, but we look at the number of days patients are enrolled in the trial. And here what we've done is actually measure the limb circumference, so that the circles are the affected limb. And as by happy coincidence, most people are symmetrical around the midline. We've then compared the same measurement in the unaffected limb. And you can see, certainly if you look at the trend lines, it does take a little while for the swelling to settle. And even by day 10, 11, there's still a significant difference between the affected and the unaffected limb when it comes to limb circumference and by inference, the swelling. We also looked at the affected skin area. So that's a percentage of the total surface area of skin. And again, this is what we're measuring here. And again, over days. And again, you can see with therapy over time, there is an improvement in the area affected. But even by day 10, 11, skin may not have got back to normal. So it's not unexpected that the limb would be swollen, and it's not unexpected that there may still be some erythema. We also took local observations about skin temperature with a digital thermometer. And again, looking at the temperature of the affected versus the non-affected limb, it's not unsurprising that actually the skin that's been damaged by the infection remains hot in comparison to the unaffected limb. And also patients still have pain. Pain continues to be an issue. Even up to day 10, 11, patients may still have pain. It's getting better, but actually it still can be painful. So I think one of the key messages from this data is actually we need to encourage and reassure patients that actually just because it's still a bit red, it may be still swollen, it may still be quite warm, it still might be painful, but actually overall, if they're feeling better, these changes will resolve and probably need no further therapy. And I think that's one of the issues that we've identified as individuals represent, because it's not completely better. And I think one of the things that we could do better for our patients is to signpost what we think the natural history and the evolution of the skin changes are going to be, so that they're not worried that if after a week or so things aren't actually back to normal, and then seek further healthcare, and then also seek further antibiotic therapy. I wanted to share this paper with you because I think this is a really nice study, although it's very old. This was published in 1937 and actually gives the experience in Scotland, in Glasgow, on their management of erysipelas. Erysipelas is very similar to cellulitis, often seen as a spectrum illness, and their treatments in the pre and the initial antibiotic era. So Snodgrass and Anderson really undertook kind of pseudo randomized controlled trial where they had 4 treatment modalities. So each individual, as they presented, they were given 1 treatment, the second patient got the second treatment, the third patient got the third treatment. And their argument is it's kind of a randomized controlled trial because patients turn up in a random order. And the treatments that they had were UV light. They would actually give patients sunburn because there was some data that either UV light or X-rays actually improved healing. They had an anti-streptococcal antitoxin, which they would administer intramuscularly. Prontosil, for those who don't know, Prontosil actually is probably one of the first antibiotics used. It's a sulfonamide. It was actually, although it was discovered after penicillin, the penicillins weren't used until the early 40s, and Prontosil was available from 1935. And as a sulfonamide, was a reasonably active agent. And then I'll come back to RI powder, but they did actually have another arm where they used this a molecule called RI powder. And this slide and the next 2 slides essentially show outcome of the various treatment modalities. The one really to look at is this one in blue, this kind of paler blue, and that's the Prontosil. But the other treatment arms, the UV light, the antitoxin, and the RI powder there in yellow. What this first panel is demonstrating actually is the number of days of treatment. So on the first day of treatment, second, third, fourth day of treatment, but then also when patients' symptoms and the local skin changes started to stop and potentially start improving. So you can see by day 2 of therapy, about 80% of individuals who had Prontosil were improving and that the spread had stopped. But I think the key thing to point out actually is that even with therapies which we now think have potentially been ineffective, UV light antitoxin, actually over about 4 or 5 days, actually the spread does tend to stop. Looking at temperatures, so this is actually the patient's temperatures. We were very good at measuring temperatures, and they were measured fairly regularly. But again, it's similar, how many patients actually no longer were febrile based on the duration of treatments and the various treatments. Again, same sort of order. And again, you can see even by day 2, day 3, although they have antibacterial, an antibacterial in the form of Prontosil, actually patients were, about 25% of them actually were still febrile even after 2 or 3 days of treatment. Again, most fevers settling by day 5, day 6. And the final one was actually a variety of systemic symptoms that individuals actually were presenting with their erysipelas and cellulitis. And again, although a bit slower, the antibiotic does seem to improve, and in time, about day 4 of therapy, about 20% of patients still had some systemic upset. But again, that improving over time. By day 6 and onwards, most patients had recovered. So again, I think it's quite a nice demonstration that the treatment of cellulitis is slow. Patients take a bit of time, even with antibiotic therapy, to improve, and that's something we should be reassuring patients about. I mentioned RI powder. This is a small subset, actually, which wasn't in the original publication, but the data is in Anderson's PhD thesis. An RI powder actually is milk powder. They gave it as a placebo to a group of individuals and monitored their response. But half of the individuals who were given RI powder actually were switched then to an antibiotic because they failed to improve. But a proportion actually got better, and you can see actually that the responses are not that dissimilar from antibiotics. And essentially, I think what I'm really trying to say is actually the natural history of cellulitis, as for most infections, is with time it will get better. The antibiotics are just improving and speeding up that time to resolution. So that's that case. So essentially highlighting the fact that patients with cellulitis, a short course of oral flucloxacillin for the majority, they will get better, but their skin changes do take a little bit of time to improve, and they need some reassurance about that. The second case is of a poorly controlled diabetic who has a degree of neuropathy. She has no evidence of vascular disease, and she presents again with a hot, swollen foot, and not unreasonably a diagnosis of cellulitis was entertained in this particular case. She was sent for an X-ray, and at that point it was reported as normal. And again, as per the previous slides, I guess if you just take a second to look at the options and think how you would manage that individual, does the fact that she's a poorly controlled diabetic change what we would do from a therapeutics point of view? So this is a real case. These are her X-rays over time, so 3, 4, 6, and 12 months. And actually, she didn't have cellulitis. This is a Charcot-arthropathy, and I'm hoping you might be able to demonstrate. And again, I hope you can see my cursor. But actually, you can see in her midfoot, the bones in her midfoot over time essentially start dissolving. Her foot shape changes significantly, and actually, ultimately, she ends up with a rocker bottom foot. Unfortunately, this one didn't end very well. She ended up actually with a large ulcer on the sole of her foot and ended up with a below knee amputation. So it really was just to highlight that whatever a red hot thing doesn't necessarily equal cellulitis. And then I wanted to introduce this term to you actually, which is called pseudocellulitis, something that looks like cellulitis but isn't cellulitis. And there's increasing evidence in the literature actually that we are really very bad at diagnosing cellulitis in the main. Somewhere between 30 to 90% of cases in the various trials are actually not cellulitis, they're something else. And that has a problem. There are problems associated with that. We are over-treating individuals with cellulitis. We're missing their primary pathology. There was a recent systematic review looking at the alternative diagnoses for these cases of pseudocellulitis, and at least 50 different pathologies can present with what looks like cellulitis as its initial presentation to the healthcare services. So the various different pathologies it could be. Not only are individuals being inappropriately exposed to antibiotics and the risk associated with that, they get admitted to hospital. And a recent study in the US has estimated that nearly $500 million of healthcare spending is actually wasted on individuals who actually don't have cellulitis. The reason I'm laboring this a little bit, of course, actually, again, what we tend to find is individuals coming back because their leg is red and hot still. It may be that a repeat course of antibiotics may not be the appropriate thing to do. It may be that actually the initial diagnosis is wrong. And what we would normally ask is, well, could it be something else going on? What I've included really are a variety of different presentations of non-infections, which actually can present and are often misdiagnosed as cellulitis, often requiring and receiving a long course of antibiotics. So for the physicians amongst us, a lot of these things are very familiar, but thrombophlebitis isn't that uncommon. Pyoderma gangrenosum in its acute form can look very cellulitic, and particularly if there's a history of inflammatory bowel disease presenting with a wound like this, I would always be questioning whether this is a pyoderma. Gout is again not an uncommon presenter. I thought to be topical, I'm not sure how many people have seen these, but there's an increasing recognition that you can get delayed cutaneous reactions from SARS-CoV-2 vaccines. And you can see the vaccine site there and the degree of erythema underneath the vaccine site presenting 2 or 3 days after the vaccine. There would be a temptation to assume that may be an infection related to the vaccine, but rather than it being a cutaneous reaction. So in order to try and help, and again, highlighting the fact that cellulitis actually is a difficult diagnosis to make, although it's a common condition, we don't have very good ways of diagnosing it. We have put together an algorithm for you, which we hope might be helpful. We've identified the various risk factors for cellulitis, and these are the things that you might think about when you're faced with a patient with a red leg, red arm. Whether they've had it before, certainly there's quite a strong link. If they've had a confirmed cellulitis before, then it probably is cellulitis. If their legs are abnormal, so they've got chronic lymphedema, if their skin is broken, if there's a history of trauma, so things like tinea pedis. If their BMI is high, there is an association with cellulitis. And also, it tends to, in the literature now, increasingly, we are seeing cellulitis being diagnosed more and more in the elderly. So the over 70s, that is seen as a risk factor. As part of the algorithm, we have included this the mnemonic, which is essentially, again, just giving you an understanding of factors you might look at, which will push you towards or away from a diagnosis of cellulitis. One thing which is very clear to me is bilateral cellulitis does not exist. It is a unilateral condition. So if you've got somebody presenting with a long history of bilateral leg erythema, it is not cellulitis. We recognise that most patients in primary care are not having blood tests done, but if you would expect them to have a leukocytosis, you would expect some degree of local warmth. So these are the sort of symptoms and signs that you might also consider looking for when presenting with somebody with a red leg. And then finally, as part of the algorithm, we have included a clinical assessment tool. This is called the New Haven assessment tool. Was published in 2018. It was from a single site and hasn't been validated yet, but we thought it may well be useful. And it'd be interesting to have any feedback on it. But essentially, the key thing is that it is new onset, so it's a short history. It has to be warm, it has to be red. There's a history of trauma, tenderness, being unilateral, and again, whether there's a white count. And also what we find actually is that most patients should really have a fever and have some systemic upset. And with New Haven, if you've got a score of, each one of these is given a score of 1. If you have a score of 4 or more, it seems to be reasonably predictive, although, as I said, this has yet to be formally validated in a large trial, but it may be helpful going forward. The guidelines have also then give you choices of antibiotics for the first presentation. So flucloxacillin for 5 days, 500 milligrams 4 times a day. If their BMI is high, then you might give a bigger dose, although the evidence for that actually isn't particularly strong. If they're penicillin allergic, and again, I think one of the things we're increasingly mindful of is that people present with a history of penicillin allergy. It's estimated that 10% of the population claim a penicillin allergy, of which really less than 10% of those are truly allergic. And if a bit of time spent trying to investigate what the nature of the allergy is may be very helpful. But if they really give a good history of penicillin allergy, we would recommend clindamycin, 300 milligrams 4 times a day for 5 days, or again, a higher dose if their BMI is high. One of the issues associated with clindamycin is a belief that clindamycin is strongly associated with C. diff disease, and we have seen a bit more C. diff in the community. So if you are going to be using clindamycin, we would suggest that you take a history of what the risk factors of C. diff infection are. So if you've had C. diff before and not been colonized, if they've had lots of antibiotics recently or have been in healthcare recently, and there's some suggestion that PPAs may increase the risk, although I'm not particularly convinced by that data. But if you see any of these potential risk factors, then you might consider an alternative like a macrolide or a tetracycline. But again, being mindful that there's a rate of resistance to these drugs, and therefore you may fail. The other thing I guess it's worth pointing out, what we tend to find is it's repeated courses of clindamycin tend to be the problem. On its own, a single short course probably is not a significant risk. And then points I think I've already laboured very much actually is about being able to reassure patients that it will take a little time. Things actually can get worse before they get better. The NICE guidance is very keen on drawing lines around cellulitis actually as a way of looking at whether it's advancing. We know the skin changes progress, and I think drawing lines is unhelpful. It tends to make individuals, patients and doctors more concerned. It's important to reassure patients also that it will get better. It just takes time. The skin is damaged, and it may take 2 or 3 weeks to get back to normal. And actually, even if it's not back to normal in that time, a further course of antibiotics probably isn't that helpful. And there is available, and I think there's a link through the guideline, there is actually a patient information leaflet which is quite helpful through the British Association of Dermatology. This is my last slide that you'll be pleased to hear. One of the questions we get asked a lot is about patients who get recurrent episodes of cellulitis, and whether there's anything we can do about that. Well, there is one trial which has looked at this, and here they did a blinded trial comparing phenoxymethylpenicillin twice a day for a year to see whether that did reduce the incidence of relapse. There is some evidence of benefit, although you can see from the Kaplan-Meier curves actually that individuals, even with penicillin, do get recurrences. But if you stop the penicillin after a year, what tends to happen actually is that the penicillin group, the treatment arm, tends to over time fall back to the placebo arm, and you then are into trouble of actually, again, they may get recurrent episodes. My personal practice actually is to offer patients the either prophylaxis or actually to give them a standby pack of flucloxacillin. Often what happens is that they have difficulty getting into primary or secondary care. By the time they present, it's quite late, and therefore there's always a want potentially to give longer courses or potentially give IVs. I think if you give a course of oral therapy with patients with a clear understanding of how and when to start taking it, you may be able to prevent admissions actually for intravenous therapy. I am going to stop at that point. I'm very grateful for your time, and I'm very happy to take any questions. on mute for a second. Shall I stop sharing, Liz?
Yes, thank you, Martin. Thank you very much for a really interesting talk. We unfortunately, I can't see the chat bar to keep an eye on chat for questions. So I said at the beginning we'd do our hands, and I see we've got the first one. Pauline, would you like to?
Yeah, hi both. I just wanted to sort of go back to the New Haven assessment, if I could, Martin, and just get some clarification there. So you have 4 points.
So it's a score of 7, and if you have 4 or more, so that puts you towards a diagnosis of cellulitis.
Sure. The bit I'm sort of interested in is if you had 4 or more, but the patient doesn't have a pyrexia or a tachycardia, how what would your threshold be for starting antibiotics? Because often I work in a minor injury department and we see quite a lot of cellulitis from wound infections, but the patient hasn't got a pyrexia.
So the pyrexia and the tachycardia actually has come from another scoring system called ALT70, where they actually take the temperature as being important. I think if there's clearly a large amount of surrounding cellulitis, I think it would be unreasonable. But bearing in mind, New Haven is for limb cellulitis, it's not for wound infections. So that's a different concept. You should really only be applying it for not ulcers or not wounds. It is for a non-purulent infection.
Okay, thank you.
Thank you. And then Nigel.
Thank you very much for the talk. I'm an acute medicine consultant from North Bristol Trust, obviously a condition we see quite a lot, as you can imagine, on the acute medical take. For those patients that do end up on intravenous therapy, I think your sort of rationale for that was those that really can't take oral therapy and are not septic per se, from what you've said. We also have this opportunity now to send people home on antibiotics into the community. And what are your thoughts on that? Or should we really just be stepping them down to orals and forgetting this community IV therapy?
I think for soft tissue infections, I think the evidence for the role of OPAT actually is not there. I think that there is very clear, if they're well enough to go home, my personal opinion is, and they can tolerate an oral agent, they should probably just go home on an oral agent. The difficulty with home IV therapies, it's great. There are lots of issues. In fact, that tends to be self-serving. If you set up a service, people want to use it. The drugs that they are using are often broader than required. So often they'll use ceftriaxone, which is quite a broad spectrum, mainly anti-gram-negative agent, or ticaplanin. And again, that really is role is primarily for a more resistant organism. So my personal view, and I know my colleagues may not agree, I think if they're well enough to have to go home, then they're probably well enough to oral therapy, bearing in mind, as long as they don't have any sinister features of evolving sepsis or necrotizing infection.
Thank you. Any more questions? I can't see any more hands up at the moment. Jodie, can I just check, is there anything in the chat?
Nothing in the chat at the moment.
No. No. Thank you, Martin. Obviously a very thorough talk, because you've not
just one question's come in.
Okay.
From Anna. I ignore my your surnames from Serona.
Jodie, do you want me to go through it?
Yeah, lovely, thank you.
Hi, Sue Wade. Could you clarify if you would use different antibiotics to treat purulent versus non-purulent cellulitis? Would you always advise to swab if purulent? And that was from Anna at Serona.
Thanks. Yes, that's a good question. Liz and we spoke quite a lot about this actually. With the non-purulent, primarily the issues we tend to see are those particularly who have got chronic venous leg ulcers. And I think the concern had been that this is a group who are maybe more vulnerable. The guideline actually is for the penicillin allergic. I think we've gone for clarithromycin. I think that's right, Liz, from memory, rather than clindamycin, purely because of the risk of C. diff, because of the patient's substrate. But bearing in mind there is a risk, and then we know that there is a non-susceptibility. Do I swab? No, I think swabs should be put in the bin, because actually they're not very helpful. Because if you don't grow a Staph aureus group A strep, the Pseudomonas, the diphtheroids, the E. coli probably are of no relevance for if you've got a chronic wound. We know that they get heavily colonized. And what we would still, the majority of individuals actually would still benefit probably from something which is driven towards the BTM streps or Staph aureus.
And we've got a question from Charlie.
Yeah, I'm a GP working in Yates. I've totally heard the message before about IVs being no better than orals, but it really doesn't seem to be getting through to the community colleagues, because every now and then, district nurses will say, has had 2 weeks of antibiotics, not better, want to do IVs. What would you recommend in that situation?
At that point, I would really question whether the diagnosis is correct. And at that point, probably an assessment, maybe some bloods. So if the CRP is bland, white count not high, it's very unlikely that this is actually cellulitis.
So just to clarify, from my perspective, what you're saying is there is no place for IV antibiotics in the community as a GP?
No, I don't think that's necessarily true. I think there are certain conditions where you have a very limited antibiotic repertoire, and therefore oral therapies may not be appropriate. But for soft tissue infections, primarily cellulitis, I don't necessarily think that giving IV therapy in the community is of any real benefit. I think oral therapy, assuming this is all non-purulent cellulitis, I think oral therapy is fine.
Thank you.
There's another question in the chat. Hi, it's Sue again. This is Rebecca from Sirona. I've just been referred a patient for prevention of admission who has had 11 admissions for cellulitis in the last 12 months. How would you recommend prevention of recurrent cellulitis?
So there are a couple of things you can do. As I say, the patch trial, which is using low dose PenV for twice a day, that may be helpful. As I've said, one of the things I tend to do is give patients standby packs of flucloxacillin, so a 5-day course of oral flucloxacillin. And if they use it, they should be able just to rein the practice and actually get that redispensed. There's been a recent trial using compression hosiery, which actually was terminated because actually it was not possible to blind it, but actually there did appear to be some benefit for people with recurrent cellulitis, actually using a moderate grade compression hosiery to prevent. And there is some, and I have recommended that in the past, if they are getting recurrent episodes, it may be that you've got a degree of lymphedema, and that may be their risk, and the compression hosiery may be beneficial for that.
And somebody did ask if we could share the slides, please. That was Jackie from Broadmead Medical Centre.
That should be fine. I've already sent the pack to Liz.
Yeah, so we can easily send those out. And just to reiterate, I'll be uploading this talk onto the training hub and sending out the link. So please do share that with colleagues you think might find it useful. Are there any other questions before we bring this to an end? No, thank you so much everyone for joining us and spending your lunchtime learning about cellulitis, and to Martin, of course, for giving such an interesting talk. If you've got any feedback or would like to see other topics, please do send an email into the Medicines Optimisation, the same email that you signed up on, bnssg.medicines/optimisation@nhs.net. Jodie, could you add that to the chat, please? And then just give us ideas or any feedback so we can build on this and do for future presentations. Lovely, thank you.
Someone's just put a big smiley face in the chat.
So typical, I can say it. Thank you, Martin. I thought that was really interesting and
was that right?
Really comprehensive. I think you covered everything that I was keen that you covered. So that's great. Hi,
Hi, Jenny.
Hi. You're so important. I've dialed in on my day off, Martin. I'm hiding because I've got my T-shirt on.
Oh, that's all right. Thank you. I hope that was okay. Anyway,
it's really interesting, and especially I like the GP's comments, as I used to be on the DN team. You've got to be really careful on the direct quote, haven't you? Yeah. Anyway, nice to see you. I'll see you tomorrow, Liz. Thanks.
Yeah.
Thanks, Liz. Bye now.